Hi there. I'll keep this short and we'll get straight into the wonderful speakers and their presentations. So the topic today is about successful aging. And when you look at healthcare and aging and the costs are linked, and both in healthcare systems as well as in successful aging, there is a need for systemic and holistic look at what constitutes quality of living, what constitutes costs, and how we can tackle it. So we have a great panel today, starting with Martin, who has been an entrepreneur himself and successfully built and sold his software company to Palo Alto Medical Foundation. And he's now the director for their innovation center. And he will talk about the programs that they're doing, such as linkages, on how they're tackling this. Then we have David, who is the executive director at healthcare programs for Citrus, which is a program of, again, University of California. And he'll also talk about the other program he does through CTA. And the way we are going to go is David will first frame the problem and the opportunities, and then we will have our guest from Sacramento, Debra, who has a company called Prevailing Health, and Prevailing Health helps senior housing companies to do occupancy development, both in the initial sales and marketing stages, but once you get a resident into the home, they want to keep him or her there. So the residents generally fall and go to a hospital and lose the residency. So keeping these people healthy and in the housing is a key feature for Prevailing Health. And then the executive director for Golden Pond Retirement, homes in Sacramento, Steve Sarayan, is also here. And guys, come on in.
Thank you, Praveen, and good evening, everyone. We're delighted to be here, and I've offered to just give a quick intro to set the stage for what you're going to hear tonight. I'm delighted to be here with my colleagues who we come from very different perspectives on this very important issue on aging, how the quality of life of older adults, services, et cetera. And I think I know you're going to get a very rich experience in terms of this entire space and the market for aging services and working with older adults and wellness for older adults. But we thought it would be important to just give a very brief overview of where we are in this area. So put together just a few slides on behalf of the whole panel to give you the context. Know that this is a sophisticated group, but in some cases you may not be familiar with the breadth of issues that are driving our work and importance of working with older adults, family caregivers, and the provider community that works with them. So first, this is an amazing time. We really are in the middle of that proverbial perfect storm. It's being driven by changes in the number of older adults we have, the vast growth in the aging population, but compounded by chronic disease issues, which is really where the drivers are in terms of cost, followed by changes and implications of reduced numbers of people who are working in this space, shortages, as we'll speak to briefly, for professionals, but also family caregivers, who are more and more people going back to work or not available to care for older adults. So a number of the factors that are driving this, most of you have already heard some of these figures in terms of the growth of the older adult population. I've worked in this space for 35 years. The number of people now, seeing how the tidal wave, the tsunami, as many people speak to it, of older adults coming is significant, and particularly just over the next decade, how many people will be aging in place in this society. Again, that simple figure, 10,000 people a day turning 65, drives what's happening in our society, not just our society, but globally. Similarly, chronic disease. We all know it around the Affordable Care Act, what's driving healthcare costs. Again, we're looking at individuals who have multiple chronic conditions being significant drivers in terms of the costs, and yet the market opportunities in this area. Again, this is where our healthcare dollars are going and where we need new solutions to address them. As I mentioned, changes in both the informal, as we call it, or family caregivers, and formal workforce. The number of people that are working in this space, the latest figures are that just in the next 5 years, we need 40% more geriatricians in this space. Nurses, social workers, therapists, you name it, we aren't going to have it. We need technology solutions to help close that gap. And similarly, we have fewer and fewer people able to take care of their family members, either because they are working or now we have such a mobile society, people living across the country from their older family members who may need a support or assistance. And similarly, in terms of the drivers within the healthcare system, with the Affordable Care Act and the triple aims that we're trying to address, we now have new drivers to reduce costs, not only whether it's reducing readmissions, but the entire system, as we're moving towards accountable care organizations, is going to change the way we provide care from that of fee-for-service to population health, managing entire populations. But at the same time, we're having wonderful changes that are going on from the technology space. Older adults themselves, not only are we aging, those of us who are boomers moving into the space knowing technology, but we're seeing across different age cohorts more comfort and greater use of individuals using technology. May not be able to see some of the figures, but just the number of people using mobile phones, again, not necessarily smartphones, but having mobile technology is a huge percentage. It's now over 80% of the older adult population. And those individuals who use information and download it has grown significantly, particularly those in the 50 to 75 year age range. Similarly, we have more information available through technology. So family caregivers, for example, this is just one model from the Pew Research Center, are tapping into information all through technology, which was is totally different than even 10 years ago. And finally, we're seeing changes in terms of how the workforce really uses technology. We have a huge presence now, as we all know, electronic medical records, and how big data are going to function in this way, both for data management, for individuals tracking large groups, but also bringing data to individuals for personal health improvement is significant. Again, physicians don't operate without smartphones now, and it's happening across the entire healthcare profession. And finally, we have the issue of technology itself. And you folks, most of you are technologists or investors in technology. You know this space. It is the speed, the rapid speed. And I'm working in an amazing university environment where I now start looking at changes in health and technology, not in the 5 or 10 year frame, but we don't even talk beyond 3 years right now in terms of what we're doing. The speed with which it's happening, how much faster, the data that can be captured, and how much cheaper it is are going to be spectacular influences on what's going to be needed over the coming few years. So with that, we thought that would just set the stage, and now I'd like to turn it back over to Deborah to talk about some very specific examples and give you the real feel for what happens in this amazing ecosystem. Steve.
Steve is up.
Steve goes next. We're right in the order we're supposed to.
We always get confused.
Thank you, David. Wow, what a great group. I'm really glad to be here today. Thanks for having us. And I'm glad we have a bunch of entrepreneurs and people who are interested in helping change the healthcare because we really need it. As David alluded to, the last 30 years of healthcare and senior care are really completely changing. We're now back on, in my opinion, the ground floor for the next 25, 30 years. So it's a good time to get involved in that, understand it. We will be it too. So it makes it kind of easy to kind of look for the things that we would want to see as we age. I think it's certainly something that I do in the programs and stuff that I put in place. But it is rapidly changing, not only technology, but what people want as far as models, what people want as far as healthcare is changing rapidly too. So it's a multi-phased approach. Hey, all right. Anyway, I'm just going to kind of go and review really what's happening now. And I'll talk about some of the pressures and some of the opportunities that I see after my 15 years of working within senior care. The goals are demographics. David covered that pretty well. Really not going to dwell on that. The types of aging services. How many people feel learned on the different levels of healthcare right now? Can I see some hands? Okay, good. Hey, how many people really feel like they know the different levels between home, assisted living, skilled nursing, hospitals? Okay. Back to the demographics, just one thing I wanted to point out is it looks like, from a 70-plus population where we're really going to peak is about 2022 with just under 50 million people in that range. So that's a pretty big sector. Another demographic to cover is a percentage of Americans over the age of 65 that are expected to survive to 90 plus. If you look at 2050, it's 42%. In 2026 and 1980, 25. So again, a big jump there in expectation of living. Martha in her home. Martha needs services. Kind of running it through how it goes. This is for home care. It's the first level of service. If it's done through a skilled set of disciplines, nursing, physical, occupational therapy, it is covered by Medicare. If it's personal care, medication management, help with bathing, dressing, concierge medicine, things like that, that's private pay. So that kind of encompasses what's currently going on in the home. I think some of the opportunities definitely are going to be around that, because the truth is when you do get into assisted living, the average range, certainly in the Bay Area, Sacramento, can be $4,000, $5,000, $6,000, $7,000 a month cash, not paid for by anybody other than the pocketbook. So not only do people want to stay in their home, but we've got to figure out solutions and technology and different ways of doing things that reduce the cost so it can be of quality. That's one of the big gaps right now. You can stay at home, but if you're all by yourself and alone, is that a quality life? Don't know. But Martha needs to move then to an assisted living. That's the next step. And there's really two categories for that type of living. There's independent, which is typically not licensed. And then there's assisted living, which is licensed by State Department of Social Services. Independent living now has, the 24-hour staffing, meal plans, some limited activities. And if there is home care that needs to be done, that's done on a private basis. Still expensive because there is no way to fractile out the cost of that. It just, somebody travels, transports, handles one person and then goes home, and they got a bill for that. Assisted living provides all the various different assistance with daily living, such as medication management, bathing, dressing, meals, all that. There's subsets in that as far as memory care, also boarding care, which actually is under the same regulations as the bigger institutions. And that's more of a formal type of a situation. Again, just kind of listing out some of the different services. Martha falls, hurts herself, then she goes to a skilled nursing facility, formerly known as convalescent home, now known as rehab. So the goal there is to get people out, short-term stay, typically covered by Medicare if they have currently 3 days inpatient at a hospital. Long-term care, typically in a nursing home, again, very expensive, and can be up to $8,000, $9,000 to $10,000 a month. Not very home-like, much more hospital-like. And what often happens in that case is by that time, somebody's spent down everything they got, and now they convert to Medi-Cal. So it's a very expensive level of service. Then the other component, much less frequent, but it is out there, is the CCRC, or the Continuing Care Retirement Communities. And on one campus, they typically have independent, assisted, skilled, and memory care. Personal observations, I think that this model was developed a while ago when people actually kind of stayed in one location, kind of worked okay. There's a buy-in typically, plus an expense as well. But it's a little bit discounted in its membership, kind of. And it worked when the family was all around in one town. But what I'm seeing now is as people are transcending through that level of care, when they get to a point of specifically memory care and certainly skilled nursing rehab or convalescent care, they're typically then moving to where the kids may be. And that could be anywhere around the country. So
can you explain what is memory care differentiated from others? Because we don't know the lingos.
Oh, certainly. Memory care is dementia care. So if, as somebody's aging, there's a high percentage of people that have one of the dementia-type diseases. Everybody's familiar with Alzheimer's. That makes up 42% of all the dementia, but there's actually 46 different types of dementia. So a high concentration of people do get that. And that's where people really no longer can be accountable for themselves, have problems with short-term memory retention, may wander, and really live in the moment at best.
There is a system like memory care, like assisted living?
Yeah, in assisted livings, it's a great question. In assisted living, there is dementia. Okay, and a typical assisted living, it just is part of the package. I'd say anywhere from, I don't know specifically statistics, but yeah, I was going to say in the 40s, over 85 have some form of dementia. Typically, it's not necessarily an issue, but as the disease progresses, what tends to happen is the person tends to pull in and forgets how to prompt to know that I'm thirsty and I need some water. So those faculties start going. So when that happens, a lot of people benefit from a smaller controlled unit with a higher staffing ratio. So a lot of assisted livings to allow somebody to age in place. A lot of assisted livings have an independent section where people can feel like I'm independent, but they're actually in a supportive environment. Then they transfer to assisted living, and as long as they're thriving and doing well there, they can stay there even with dementia, as long as they're thriving. But another portion, again, after they thrive for a bit, start to really deteriorate. They stay in the rooms, they don't eat, they lose weight, they stop socializing. And we found when we have a special unit that's controlled, the energy is controlled, staffing ratios are twice as much as they are on assisted living, so they're engaged, and there's all-day programming to where people are engaged at shorter bursts. Activities are another thing that are different that way. And the security, of course. People then typically blossom back out again and have another quality of life, towards the end. Okay, good question though. This just kind of runs through and shows what I just discussed about the average monthly rent. ADL's number of units for an average facility. The common model for assisted living right now is somewhere between 60 and 80 units is where they kind of maximize the staffing and the revenues. And then this is an analysis from Senior Housing Research Report, just kind of showing for this last year and coming into the first and second quarter of next year, just that, even though a lot of businesses through the housing decline and the stock market decline, assisted living really kind of held because it is need driven. It didn't flourish. There wasn't a lot of new construction, if any. I don't think any. But these kinds of indicators and signs of independent living being projected to be at 91.5%, assisted living being on average 91%, again, is really, and again, interest rates, REIT money, things like that, really spawned a lot of growth right now. In Sacramento, as an example, I can speak, in the next 2 years, there's going to be 2,200 new doorknobs for assisted living. Every one of them is going for the $6,000, $7,000, $8,000 high-end market. That only the top 20% of the population can afford that. The bottom 30% of the population, somewhere the government's going to have to help with that. They're going to have a solution. That leaves 50% in the middle. That is the average person that there's going to be needing some solutions out there. They can't afford $50,000 and $75,000 a year cash for any length of time. And again, that's where the call on the entrepreneurship, the investment dollars, things like this, to really help address this need for the average person. We need the help. Okay. This is the common factors for what is coming into assisted living, as we see. There's 42% have arthritis, 38%, there's your dementia question, have Alzheimer's, dementia. 33% have heart disease, 30% have depression. Again, one of the new programs that I'm working on is I have marriage and family counselors and social workers that work proactively with the seniors, going off the fact of really trying to bridge that quality of life. So a lot of it is reaching out and being proactive. It really is about being proactive. And then osteoporosis is another problem. Here's the top 5 reasons for moving into an assisted living. The first is medication management. And I don't know about you guys, but even if I have like one antibiotic I got to take a day for a week, it's amazing how difficult it is to remember to do that. Well, imagine some of these seniors that take three med passes a day with 12 or 15, 18 medications. Very difficult. And compliance in the home is not very high at all, and that ends people up in the hospitals. So, from a solution standpoint, there are medication management machines that are now coming on the market, where a nurse can come by and load them up for a month, and go. And it has an alarm and alert and spits out the pills like a Pez machine. And so that's one way right now. It's still not perfect by any stretch, but that's an opportunity to help reduce that move in. Falls is a huge reason. Fear of falling, people who do fall, anyone who has a parent that lives at home alone, it's got to be in your mind. Did mom fall? Who's going to know if she did? Deborah's, I think, going to talk a little bit about some stuff that she's been working on with that too, but I've also heard there's a lot of technology out there as far as being able to really monitor someone while they're alone in the home, because if somebody falls, and no one's going to know about it for even a couple days sometimes, and it's a terrible feeling, and I think a big fear. So that forces, again, increased costs, because if mom's home alone, I'm afraid she's going to fall. I'm going to try to get her into an assisted living facility, but it's going to cost me $5,000 a month. So maybe there's a solution that can give confidence to that and stave that off. The social and isolation piece is a big one, and probably one of the biggest out there as far as being in the home. So if you're safe and if you have all the other stuff, you need more than the TV to keep your brain going. And again, technology can address that too, through Skyping and multi-different medias there. I just think that there's some opportunities to bring it closer to the senior and make it a little easier, because again, although they are starting to play with iPhones and starting to understand computers, that kind of technology is still a little difficult for them to really grasp, I would say, on the whole. But it's important, and certainly as the aging population comes in, they're going to welcome that. within even the next 3 to 5 years. I think it'll be expected. We should Skype everyone everywhere. So good opportunities there. Memory issues and wandering. And I think this is a big one. With such a high percentage of people with dementia and dementia care in an assisted living. So if it's $5,000 to go in assisted living, add 2 more thousand if you're going to go into a memory care unit. Okay, so we're really talking some big bucks. And one of the biggest fears of someone with a little bit of memory impairment or dementia is that they're going to wander and they're going to forget how to get home. They may be driving, and that's actually one of the biggest signs of dementia out there for people that are just trucking along. They're compensating for it, and they've driven this way for 40 years, and now they forgot how to get home. That does happen. So wandering is a big issue. One of the technologies of a company that I'm working with, who's looking to expand in the U.S., they're based in the U.K., is it's a digital watch that has a GPS. And anytime they break the barrier of the home on radio signal, it clicks off to the GPS monitoring and tracks them within 5 feet, sends a text and an alert to whoever is the caregiver. So if I was there, I could go, oh, Mom just broke the barrier. What's she doing? I hit the link and I can watch her real time walking down the street going, okay, I better get somebody out there to get her. But if you think of it, that's huge. And as a director in assisted living, there's nothing that is more scary than being responsible for somebody and having them exit the building and not knowing where they are. There's nothing worse. So that kind of solution would cost $100 a month. To have that as an example versus, again, the 5,000, 6,000, 7,000. So you can see how technology can really help slow down the from home right to assisted living and right into the matrix of the senior healthcare. And then lack of good nutrition is another big aspect. And there are Meals on Wheels concepts out there. And I think, at some point in the future, having a good dining meal program, so the nutrition by dietitian is there, that's a big case, especially with all the other things that go in here. Seniors, especially that live alone, just go, I'll just heat up that piece of cheese again and have that for dinner. I don't feel like cooking. So, and again, with the medications, with the aging, with the dementia, all those things tie together. And you end up with bad outcomes that send you back into that senior matrix of expense. So a lot of opportunities for you guys out there. Okay, any questions? Yes?
Just a comment, because you're throwing out the different numbers for cost. I think it's important to recognize as well that very rarely does a spouse age at the same rate as their spouse. Mm-hmm. And so you have one person who might be living in an assisted living at $5,000, right, and then their spouse at $8,000 in the memory care. The numbers really start to compound. That's a great thing. And also, too, what happens is a husband and wife couple come in, and it's really because the wife or the husband needs it. The other guy's just like, what do I do? But I got to be with her. And then that's a great point. Once you get split up, because you're not always going to go down that same path, then you're just bifurcating it off and you're doubling the costs. Very true. Yep. Okay. Well, I know we're going to have question and answers. I probably hit my 15 minutes right on. Didn't I? Did I? I don't know. Felt like it. Thanks, everybody.
Thank you, Steve. Goodbye, Martha. Okay, my name's Deborah Draves, and I am a certified licensed RCFE administrator for the state of California, but I don't practice. I am a consultant, predominantly to the senior housing industry, and consultant is a terrible word. What I try to do is help people in senior housing make more money by attracting new residents and hanging on to them as long as possible. Now, that sounds terrible because we're talking about grandmas and aunts and mothers. By the way, how many of you, just by show of hands, how many of you have ever had a mother? Good, we're connecting. Good. And I have a joke. I do have a joke. So a physician is doing dictation in his office, and the nurse comes in and says, "Doctor, your 2:00 patient is waiting for you in exam room 3. Mr. Baker is 92 years old, and he has his parents with him." It's a good one. You liked it better than anyone else, though. Okay, I'd like to talk about in a little bit more depth than what Steve did about the challenges to extending occupancy in senior housing. And why are we focused on senior housing? I'll tell you why it might be interesting for you to be focused on senior housing. Number one, it is the perfect incubator for technology for older adults. Think about it. Most assisted livings are around 100 apartments. Most carpeting, furnishings, food, environmental aspects are all the same, which means variables are minimal. You have a demographic that is all in the same nice row for your graphs. It's wonderful. And as a testing unit and a focus group unit, speaking from a marketing standpoint, all those residents talk to each other. So if you can get some early adopters on a new idea inside a senior community, you can test it really quickly. Compressed timeframes. With very interesting outcomes that if you were doing a traditional focus group, you're not going to get. So that's one reason you may want to pay attention to senior housing. The other reason is, quite frankly, aging is in all our future. And senior housing, for all its foibles and how imperfect it is, right now is one of the key reasons that older adults stay healthy. Now, predominantly most older adults, and myself included, I want to stay in my home. I want to drive until someone pries the keys out of my hand, and I want to stay in my home. But the truth is, staying in my home when I am eating soup for one every day and watching television as my only socialization and waiting for my daughter-in-law to come take me to Walmart is no way to live. And it's not healthy. So if we can get personal care companies to come in and connect those residents, if we can get programs like Martin's to connect those residents, perhaps, imagine this, provide some other reason than the television to get out of bed in the morning. How about using the skills that you had when you were an active, unretired adult? How about recycling some of the expertise that are sitting in Steve's community, the CEOs and the accountants that are in our senior communities, that they're retired and so we dismiss? I'm here to tell you, as an advocate for older adults, because I am one, and I'm becoming one, that one of the greatest things that we squander in this eco-obsessed, recycle-obsessed society of ours is the wisdom of our older adults. So imagine providing opportunities, not just for the health and safety of someone. When I'm old, or tomorrow, or next week, I don't want someone to provide for the health and safety of me. I want to be useful. I want to matter. And if we provided opportunities for older adults to matter, I contend that our healthcare problems would decrease. I contend that folks that sit all day in front of a television would actually get up and do things and be happier. I don't want a longer life. I want a better life. And I bet every older adult in your circle feels the same. I will bet. Okay, so what happens after one trip to the ER? That's my soapbox. I'm moving on. One trip to the ER can be devastating, so we want to avoid that. And the major threats to independence, besides the feeling of not being useful, are falls and memory issues. We're going to talk about those really quickly, too. Okay. All right, let me ask a question. Who wants to wager a guess on what the average length of stay is in an assisted living?
20 years.
20 years. A little bit less than that. Who wants to? 2 years. A little bit less than that. There you go. That's a good reaction. Really? Yes, really. Used to be 21 months. Now, the American Federation of Assisted Living has just published average length of stay, a month and a half. I'm a year and a half, 18 months. Sorry. You guys are listening. That's good. Average resident turnover. So if you look at our building here, it's half empty. I'm an occupancy development consultant. This is terrible. Every 12 months, almost half your building turns over. Now that gets really expensive when you're spending all this money on sales and marketing. As a matter of fact, I was in charge of all the sales and marketing in Eschaton. If anyone knows Eschaton, it's a little company over in Sacramento. And I did a study on this. Our average cost of acquisition for a new resident, 6 to 9 months worth of that abominable rent. 6 to 9 months. And if I'm only keeping that resident 18 months, I am losing money. So the one thing we can't really manage if we're in the senior housing market, because you're all with me now in the senior housing market, can't really manage financial problems. Okay, it's a rental. If you can't afford it, well, we have to help you find another solution. And one thing I can manage are customer service issues. If you're moving out because you're not happy or the food is terrible, that I can manage. That I want to know. But if you're moving out for health-related reasons, which here's my building half empty again, that's a problem. And as an industry, now we're regulated Department of Social Services, not health. As an industry in assisted living, Department of Social Services says, I can't deal with health issues. Not my problem. It's out the back door. Mabel fell. Joan has a urinary tract infection. She needs to go to the emergency room. And for years, the industry has been like that. Well, I spent a lot of time getting Mabel and Joan into that building, and the last thing I want to see is this concentrated group that's supposed to protect this resident, provide this wonderful environment, go, yeah, I know, she's been falling for months. Or, yeah, I know, we knew she had an infection, but that's terrible. Now, is that health care? No, it's not. Is that good care? I would say that's good care. If you're actually preventing someone from going to the ER because you've called their doctor and said, her balance is bad, can we get a physical therapist to come in and do an evaluation? I think that's good care. That's me personally. Okay, why is it important to keep older adults out of the emergency room? Why is it important, Steve?
Count the ways.
Here's some technical stuff. From MedPAC 2 years ago, 60% of all Medicare payments to the ER were for incidences that were preventable. That's Congress saying this person that we're paying out on didn't have to be here. There were clear indications that this ER visit was predictable. That's terrible. And the worst part is one ER visit can severely impact the health of anyone, but especially an older adult. Why do you think that is?
Airborne disease.
Number one, hospitals are where the germs are. That's no joke. Hospitals are where the germs are. And if you've spent any time in an ER lately, you probably spent about 6 or 7 hours in the ER. It's not pleasant. Imagine that when you're twice your age. It's cold, it's impersonal, it's where the germs are. And they've done studies. They do studies about everything, but this is a very interesting study that Kaiser actually published. It's a non-hospitalization, meaning they took 230 older adults over 65 that ended up in the ER. They were not hospitalized, okay? So they got patched up and they were sent home. 230. Over half of those reported, self-reported, they were completely independent. I get up, I can dress myself, I have stuff to do, I'm independent. I don't need personal care, I don't need anyone to make my soup for one, I'm good. After the ER visit, this is the scary part. That dropped to a third. One ER visit, no hospitalization. Symptoms of cognitive impairment rose 6%. So you lose your memory. And patients who could not walk without an assistive device rose almost a quarter. Now, we're here to talk about solutions, okay? Staying out of the ER is a really good solution. But as a provider trying to keep residents out of the hospital, I did some research. And one of the most interesting, and Martin, I don't know if you've heard of these guys out of Minnesota, Bluestone Physicians, they are a house call physician group. And they take care of 85% of all independent living and assisted living residents in the state of Minnesota. And do you know what? They have cell phones. They have smartphones. And do you know what else? They answer them. Why is that important? Well, if you tell a Bluestone physician that Mabel is unstable and I need orders, or perhaps we should think about orders for physical therapy because her balance is bad, you can get orders within hours, not days, not weeks. What does that mean? Saving trips to the ER. Now, according to Bluestone, I've talked to these guys multiple times. This isn't my observation, this is their observation. There are four main reasons why their patient groups, which is 85% of the senior community dwelling residents in the state of Minnesota, end up in the ER. Number one, medication management. There is that term again. There might be opportunity there. Medications. Medications for older adults is a mess. It's a mess. There needs to be management. There needs to be better solutions. And there's a bunch of really smart, brilliant people in this room. We could figure out how to deliver medications better and manage them better. Second one, falls. We're going to talk a little bit more in detail about falls. It's my favorite thing. Who knows what a UTI is? Urinary tract infection. We don't want to talk about that. And we certainly don't want to talk about constipation, which is the nice term. Okay? That's the stool softener term. What this group is really talking about, I'm going to say it, fecal compaction. I can't believe I said that. That's horrible. You guys are sitting there going, I could be watching Thursday Night Football, and she's talking about poop. Is Bluestone important? You bet it's important. Because since their inception, almost 7 years ago, hospital admissions on their patient base are down 80%, actually over 80%. I can't overemphasize how important that is. Now, is house call physicians high tech? Maybe. Could telemedicine replace that? Oh, you know for a fact they're experimenting with that. I think the important thing, though, is the accessibility part. The physicians are going where the residents are, and it's responsive. It's not urgent care. It's not waiting until something actually happens and then the facility calls 911 and the ambulance comes, which is the way that healthcare is managed in assisted living today. Oh, a great way to prevent falls. And I mean it. The best way to prevent falls, resist the temptation to get a scooter. And, by the way, this is a great way to prevent fecal infection. Why? These organisms that we were gifted with are designed to move. If they don't move, things get bound up. Other things deteriorate. It is a fact of nature that we were designed to move and walk. And that is the healthiest thing that we can do. And if you're going to get one of these, then don't allow anyone to ride inside. They're designed for outside. So medication management was one of Steve's top 5 things. And he mentioned the canisters, the Pez dispensers. The Philips product here is probably the most well-known. We love to call it the coffee can. It's aesthetically sort of bulky. And it manages lots of complex regimens. It's actually a really good solution for someone that if there's an alarm there to take your medication can actually take the medication. That's great. There's a couple things could be improved though. So those of you who are looking for ideas, here's a couple things that could be improved. It still needs to be filled once a month, which means a nurse has to go out there or the family has to go out there. Those of you with pharmaceutical connections, particularly retail pharmaceutical connections, why wouldn't Walmart want to just do these as canisters? That to me would make the most sense. And then the other problem with this really is that you don't have a pill bottle anymore. Or if you have it, it's in the drawer and it's not now associated with the different cups. So if you want to take your mom on a vacation, you gotta open it up and figure out what pill goes in what bottle, and it's really messy. So to me, a better design would be to take the pill bottle but that's just an idea. Just an idea. Medication management is the number one reason an older adult goes from independent living to assisted living. It's the number one reason why older adults move into assisted living. So, opportunity, yes. Number 2, falls. The fear of falling is actually more dangerous than usually the fall itself. Why? It's physiological. If you're afraid, what happens? Your center of gravity goes way up around your shoulders, your knees lock, you do the Frankenstein walk, and you're really easy to push over. Fear of falling also prevents moving. And if you do not move, what happens? You atrophy. You do. Your muscles stop growing. The energy goes elsewhere. Nature does it in all kinds of ways. Okay, I want you guys look really sleepy and I'm almost done. If your first name begins with one of these letters, stand up. AJLMS. I can always remember it. Always just leaves masses satisfied. Okay. Now, would you say that approximately this is about a third of the room? It usually works. These top letters are the top 30 most popular first names. And this is a really good way to get about 30% of the building or the audience to stand up. Now, if any of you or all of you were over the age of 65, every single one of you standing would have a serious fall by next October. %30 of you of this entire room will have a serious fall if you were over the age of 65 by next October. I didn't say you could sit down.
I don't agree.
Okay, so all of you who are standing will fall down. So please don't. Please sit. 30%, a third of every older adult over the age of 65, not even in their 70s, serious fall once a year. The World Health Organization considers it a fall epidemic. How am I doing on time? Oh, okay. Fall epidemic, World Health Organization. This is not an American problem. As a matter of fact, India is the #1 country in the World Health Organization for death by falls. China's 8. We're 80th. The United States is 80th. Falls are the #1 across the board, #1 reason, cause of death for injury-related instances. Boy, that was awkward. Injury-related deaths, falls are #1. And older adults are really, 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 really frightened about dying in a stinky nursing home as a result of a fall. It's a prediction because over the age of 75, anyone who falls has a 4 to 5 times higher rate to spend a year or more in skilled nursing. I didn't stay stinking in the nursing home. Myths. Restricting physical activity reduces falls. No. Sedentary lifestyle reduces falls. Absolutely not. Falls are inevitable. Everybody's going to fall. Falls may be inevitable, but serious falls are not. And the biggest myth, who thinks osteoporosis is just a normal part? Who thinks atrophy, muscle atrophy, normal part of aging? If osteoporosis was a normal part of aging, then the space program, NASA, would not have been so alarmed by the fact that they sent all their healthy astronauts out into zero gravity, and one of the #1 side effects they had? Osteoporosis. Our bodies need stress to produce calcium and the minerals to keep our bones strong, which means we need to stand up and walk around, get up and down out of chairs, do stairs. We're meant to move. The less you move, the less capability you have to move. So, a couple things you can do. This is according to the Centers for Disease Control. Falls are not just a thing that happens. It's just not an accident. The Centers for Disease Control is concerned about falls. What can you do? Begin with exercise. Exercise. I may have a little company looking for some angel funding around senior exercise. Ask your doctor or pharmacist to review your medications, because if you've got medications that are making you dizzy, guess what? You may fall. Eye checkups, make your home safer. This is the occupational therapy part of things. But this is not my recommendation and my prescription. This is from the Center of Disease Control. So last thing is memory issues. That's it. Does anyone have any questions so far? I've been just I could take a breath. No questions. You got it all on falls. Okay. Memory issues. Memory issues are a more difficult topic, I think. But falls can be devastating, but memory issues are difficult. And the truth is, memory issues can range from, gosh, Martha, she can never remember what time breakfast is, and it's cute, to Martha now doesn't recognize her husband anymore, and it's not so cute. Alzheimer's is a horrible disease, and we really don't have a whole lot of traction on it. And the truth is, over the age of 75, it affects 1 out of 9. 1 out of 9. Doesn't mean that it's the horrible kind, but some form of Alzheimer's is out there. And again, it's a global crisis. Falls are a global crisis. Alzheimer's and dementia. I think these slides are going to be available, so we don't need to go over all the statistics. But in America, from 2013 to 2015, our incidence of dementia, not Alzheimer's, but dementia, which is forgetfulness and disorientation, up 248%. Part of that is because we're living longer, okay? But still, 1 out of 9. There's a bunch of facts. We're not going to go over them. It's terrible, and it's pervasive. That's the facts. Normal memory versus dementia symptoms. The Alzheimer's Association is brilliant in all these kinds of tools, assessment tools. But the fact is, Steve hit the nail on the head. What is important with a memory or dementia, a person, an older adult affected by memory loss or dementia, is, number one, safety. Number two, a good environment. Not a terrible environment, but a good, stimulating environment. And sometimes that isn't a large senior housing project. Sometimes that's a six-bed board and care is a perfect environment. There's lots of resources on Alzheimer's and dementia, and this is another space. So medication management, just to wrap, medication management, falls, fall prevention, fall detection. We've got all the tri-axis accelerometers that tell you when you fall. You know, I fall and I can't get up, and now you know exactly how fast I fell. Med management, falls, and memory care are 3 key areas where we could use a lot better ideas, solutions, technology. If you want to play in the senior housing or the aging services space, make your incubator in senior housing, take a look at med management, take a look at fall prevention. We've got a couple of solutions up here if you're curious, and wandering, dementia, memory issues. Any questions?
So just to jump in there, like you're talking about fall prevention and all the rest. It seems like if you actually can address a little bit more the exercise component of things, then it actually solves a lot of the problem. So you mentioned people going into hospital. I forget the actual numbers. I think it was 54% going down to 33%. Afterwards, being not independent anymore. People going into these facilities in the first place, can you actually be a little bit proactive and actually say that if they are a little bit more active, then you get rid of the nutrition issues, the memory issues, and medication issues, so that they don't actually need these services? Because actually, like, a lot of the wearable or quantified self has been focused on the active population, which I think is ridiculous. But if you have then infants or aging population, there's an actual need, and then that can actually address things. So just wanted to get your feedback on that.
Well, I'm not sure there was a question in there, but I think everything you said is spot on. The first of which being, if if our communities were more proactive with exercise, fitness, and emphasis on don't ride inside. A simple thing like we don't allow scooters inside. We'll help you walk to the dining room. We'll give you a ride occasionally. But it's our policy as an active adult community that you're active because it's not only good for you, it's good for everyone. So that's the first thing. And then the wearables of the focus on the fittest folks in our society is, you're exactly right. Why are we focusing all this wearable technology on the folks that probably don't need it as badly as the folks that could benefit from it? The infants, folks with memory loss, older adults. Absolutely. And think about, now if you start to think about and expand the parameters of the wearable market, there's so many huge needs in the senior market.
One thing we'll do, Deborah, is take questions later. We still have a couple of speakers to go.
Sorry.
No problem. Thanks.
Not a problem at all. And thank you very much, Steve and Deborah, for setting the stage for us. Because I think what you've done is put together some very practical issues, the very common issues, particularly around chronic disease in the later part of the age spectrum. So I'm going to try and do a little bit of the impossible, and that is squeeze my time down very much. But I do want to first put the material that I have into context from the historical work we've been doing, both at Citrus at the University of California, as well as my Center for Technology and Aging, and give you the context for where these different ideas come from. But then I'd like to frame a little bit differently what Steve and Deborah were doing, because it's also important to look at this full continuum. So I'm going to focus on a bit more of that earlier age category and higher functioning issues, because we have a huge range, not only chronological age, but functional age. And I'm going to be speaking to, in a sense, what we're saying, 60 is the new 40, 80 is the new 60, and what we're doing in a number of these areas to give you an idea of the market and many of the technologies here. And then I'd like to end up just giving you a few ideas where we see the future going, particularly, as I said, just a few years out in terms of where technology is moving in this space. I know we have both investors, entrepreneurs, startup folks here. We actually work in that space. Citrus is a program that's funded by the University of California over all the campuses. We actually work multi-campus, 4 different campuses, Berkeley, Santa Cruz, Merced, and Davis. It was established 12 years ago and has been a primary function of translating services or research into practice, actually. It leverages a modest amount of state money, $4 million a year into $100 million, a 20x return. We are involved with 80 faculty, core faculty, but actually 350 investigators and several hundred postdocs and doctoral students from engineering, clinical services, right on through to public health, public policy, business school at Haas, et cetera. We've been the primary driver of new startups in the UC system. At Berkeley, we have over 50 companies. We just selected 5 more in our incubator. So we have built out companies, and we're much broader than healthcare. So I won't speak to my colleagues' areas of energy, infrastructure, and civic engagement, but I will talk now about what we really do in these areas. We not only have an invention ecosystem with the largest nanofabrication facility in the Pacific Rim, but also, again, now multiple mechanisms for bringing new ideas to practice. We have a range of different mechanisms for doing that, from seed grants to sponsorships to convenings, but of course our primary bread and butter is to do everything from SBIRs to NIH and NSF funded projects. The Center for Technology and Aging, which a lot of this material is coming from, I brought into Berkeley, where we are moving into the idea of how we can take proven technologies into the practice to help in terms of addressing health and well-being issues for older adults. We have a number of issues that we've worked on, but primarily focusing on new strategies that address the Affordable Care Act challenges. We've worked with over 100 different healthcare systems around the country, primarily in these 4 areas: on medication monitoring and adherence, key issue, but but also remote monitoring and looking at care transition strategies where technology can have a huge impact, and now moving into mobile solutions. I'm going to move past that, but you can look in our website for some of the impact programs where we have had very successful programs ranging from large systems like Sharp Healthcare in Southern California to home health agencies to other programs that have addressed issues around readmissions, patient satisfaction, and most importantly, in this day and age with our healthcare system, looking at how we can address the ROI of programs and really reduce programs. We're now coordinating actually in the development of an ROI tool funded by the California Healthcare Foundation to help organizations determine what technologies will help their healthcare system, their hospitals, their physician groups in picking technology solutions that'll have the greatest impact on their patient population and reduce costs. So again, I'll leave for later and for your review. You can pull it up on our website, the different models and programs, many of which, and this is what we're really all about, looking at scaling and sustainability, where we did select programs that have now gone to scale, have become national programs, and are still quite successful at this point. Just for those of you who are in the technology space, looking at healthcare overall, healthcare for older adults, we did come away with a number of very specific solutions because this is my one takeaway on this section. Technology is not the key issue. It's 10% of the issue. 90% of the issue is around deployment, adoption, the human factors. And that's what we keep reinforcing, that when we're looking at tech solutions, we do know that there are a number of factors that go into making them work, but again, it has to be fundamentally based on the system that you're working in. We came up with a whole toolkit of takeaways from these organizations. They're available on our website for those of you who'd like to look at them. They have a fair amount of generalizability as you're looking at programs that work within the healthcare sector in general. What we've done then, merging a lot of this, my colleagues in the multiple centers here, are looking from a problem-based issue. What are these fundamental problems, as Deborah and Steve have said? Looking at falls, looking at medication adherence, looking at basic communication strategies that we need in this space, looking at how we can then link multiple technologies together to address or come up with transformative technology solutions, not just incremental change, but how can we really move the needle in this space? Our focus areas have been around telehealth, telemedicine. At Davis, we have the second largest telehealth program in the U.S. It now reaches 800 hospitals and health systems and ambulatory care clinics through California, second only to the VA. We're in the area of developing new sensor technologies, which I think would be hugely interesting for a number of you and the potential collaboration with our research teams, particularly around passive sensors. We have groups now working particularly from Santa Cruz and Davis in areas around new app solutions, mobile, and of course gaming from the behavioral perspective. But where we're going now, and I really want to reinforce, is how we use big data in this area. That is the linking factor, and that's where we see the next 5 years being fundamental for tech solutions. Again, same takeaways as Deborah and Steve said. We're looking for how you improve the well-being of older adults, whether it's in a residential setting or helping people stay at home as long as possible. So where have we taken that? And this is where I'll just give you a framework, and I won't go into details. In fact, the material that we have here, you not only can have the slides, but I brought a couple of dozen of the white papers that really puts the next few slides together of how we've sort of categorized this and look at opportunities here. We've put it actually, the whole area now that we call connected aging and how it supports what we also call the longevity economy. This is what we're now dealing with for the aging spectrum, not only for older adults, but their families and the entire societal system that has to work in this area. We've broken it out into several areas. It's not exhaustive, but just some buckets for you to consider in terms of some of the solutions. You've heard great ones here tonight. Martin's going to give you one of the best ideas that PAMP is coming up with. So we'll turn it over to him to give you a perfect example. But I would like to try to help you think broader in terms of where these opportunities are from a startup or areas where you can have an impact in this area. We also are working with a number of with VCs in looking at these areas, and the very first venture firm that's been put together to focus only on aging issues coming out of the Midwest. So I'm going to leave you at the end with a few examples and resources and organizations you can turn to if you have interest in this space. So very quickly, I'll take you through these 4 areas. First, looking at the quantified self. This is a spectacular area. It's not just the Apple Watch and our new measurement. We're working with Apple and Google on some of these issues, but it's really how individuals can track themselves, do preventive work, and how this, again, will translate into programs, as Steve and Deborah said, to help us monitor individuals as we have functional challenges moving forward. Specifically, as we're looking at the Fitbits, Jawbones, et cetera, we're seeing the possibility, particularly as these technologies move from the ubiquitous band to even more finite or smaller sensors, and those that'll be linked seamlessly through mobile devices, a new mechanism that we can track people at any part of the age spectrum. This is where information is occurring, and this is where big data, when it can be brought back to you as an individual, is going to be transformative in terms of how we age, how we can control our own health. This now speaks to much more of what Steve and Deborah were saying in terms of the home environment, where we're looking at passive sensors. And by home environment, we're talking about the whole continuum of residential programs, ranging from staying in your own home, which is the gold standard for everybody, to moving through this important continuum of care we have, and how we can build in now sensors to actually track individuals, not only their movement to protect them, those who have cognitive impairments, but also actually controlling our environment, which we're seeing. Several of these technologies in the last few years have gone to market and are getting a significant traction and are going out in the consumer product space. WellAware is one program that links many different capacities or programs where you can actually measure and control what is going on in the space, not only healthcare data from individuals, but looking at the fact that you can know what's going on, whether a person left a stove on, whether you can control the environment from remote areas, whether you can even communicate through a television screen, which is probably going to be still one of the major ways that we'll see communication going on in most settings, whether it's the home or a residential program. But let's expand this thinking again, because now we're looking at how do we tie people together? How do we deal with these issues we talked about in terms of community, linking people to each other, whether you're have a family member long distance away, or you need to get information. So many of these programs that are coming together, and this is where we're seeing programs like Patients Like Me, which allows patients to work together very quickly at any age in terms of getting information, finding cohorts that can help themselves, or programs like Independent, which is based out of Southern California, which is put onto a lot of the functions that you're going to hear about that are done beautifully here at PAMF, being put into a tablet format that can allow people to control and have input on many areas around of their entire life. As Deborah said, she worked at Eschaton. It's these large systems are looking for types of programs that can control many different activities or allow a person to move into that space. And finally, moving out into the caregiving space. Family caregiving is the primary source of where healthcare is delivered. Family caregiving drives our system. I'm also on the Executive Council for AARP of California. Caregiving is going to be one of our major pillars going forward. It's a major pillar for the national office. We have one of the premier programs, Family Caregiver Alliance, in San Francisco, which covers California in terms of people, particularly with head injuries and other brain impairments. Family caregiving is an amazing space to be moving into from a technology perspective. And this is where, again, I'd love to turn to linkages as being a place that links families together, individuals in a very wonderful continuum. And you'll hear more about that shortly. So I'm going to wrap up by saying, what is next? Where do we see things going? And we've put together a couple of things around this. First, building on what we heard earlier, we're dealing with a new healthcare environment. We're moving from where people have been taken care of for their health, are now going to be responsible for their own health. Where we've looked at individuals, we're now looking at population health. Kaiser is going to be the norm. We're looking at how we move from just professionals to really counting on families and other individuals to be part of this system. So we're moving in this way, and technology is the link between it all. We also have the drivers, not only Affordable Care Act and the way technology is changing, as we talked about earlier, but what people expect to use and what they're going to anticipate when you go in and you can actually do things remotely as opposed to go into a physician's office. When you can get information, more people now get their information on a healthcare issue online than from a nurse practitioner or physician in their office. So where are we going? We did a review and came up with 12 areas. I'm not going to go over all of them for a lack of time. In fact, I'll just focus on 3 for you quickly. I have this whole list, but it ranges again from robotics to different fall prevention techniques we're talking about. And in falls, I'd like to reinforce prevention. We're now moving into that space where we can detect gait disorders, we can track individuals, and that's where the space is going to be. Not tracking or monitoring falls, but preventing them. Similarly, medication assistance and adherence. I'm going to share what I see a major transformative change, but a number of issues ranging with from communication to sensor improvements. So 3 of them. Big data is going to be the biggest driver in this space. We're talking about electronic medical records, how they're going to be connected across the board. PAMP has a spectacular system. Kaiser is one of the best in the world, but it's how they're going to be linking that EHR to all elements of the care continuum, to providers, and again, getting actionable data out of it. Not just collecting massive amounts of data, but actionable data for practitioners and for individuals. Similarly, in the smart body sensor medication management movement, we're seeing some wonderful new solutions coming through. I've already seen several sensors in terms of tracking that could be breakthrough in terms of glucose monitoring, for example. Diabetes being one of our highest issues in terms of driving the healthcare costs and chronic disease. When we can create non-invasive glucose strips, and we're starting to see those, that's going to be a breakthrough technology. But in medication management, I actually beg to differ from where we're going with the traditional Philips and other medication dispensers. This is Proteus. Proteus is now a technology that's been approved and used in the EU. FDA just approved it. It's actually a chip on a pill that is able to deteriorate naturally in the body, but that chip can tell what the dosage is, what you've taken, when you've taken it, reports it to a patch, which then goes directly to a provider. You can tell, and this is now going to really transform how we monitor and manage medication, what a person's taken, what they haven't taken. It's going to be a major breakthrough, and so they're actually now moving into the U.S. market pretty significantly from Europe. And again, big data and analytics, because this is where we're going to move people in terms of how we track information and allow not only individuals, older adults, but how we get people involved in taking charge of their own healthcare. That's where we're going to see the major changes going forward. And we're going to do it in some very interesting ways. Sensors are getting so much smaller. Many of the things that older adults don't like are wearing pendants, a personal emergency response about falling. If you can turn that into jewelry and make it something that people don't even think about, and then have it interactive where you can communicate immediately with a person if you have had an accident, that's going to be breakthrough. But that's just the beginning of how we're going to have ubiquitous, very seamless technologies to work in this space. So what I'd like to leave you with is that the technology we're all interested in it. It's still just a tool. and it has to work within the fabric and the environment of where older adults are, their family members, service providers, et cetera. So I highly encourage you, as we do with all the startup companies, the research teams we work with, to first and foremost work with older adults, work with service providers. That's where you learn what's going to work and what's needed. And so finally, just a few resources. And again, I'll leave these slides for you. Items that we have in terms of what can be downloaded from our different web pages, but also some organizations to share with you that I think are important. Aging 2.0, Katie Fike and Steve Johnson are doing a wonderful job. They're based here in San Francisco. They've created a whole environment for startups to get mentoring and move in this space. The Linkage Ziegler Group, it's a different linkage group over in Ohio, has not only our group purchasing organization for 990 of these large continuing care retirement centers, but have now the first venture fund, targeted only at these types of technologies. Age Tech West is part of Leading Age here in California, who they've also connected with Oregon and Washington to bring together many different service providers that are looking for your technologies, and they will do prototyping, they will provide access to their populations and their facilities for you to test out programs. And I can connect you with Scott Pfeiffer, who directs that program. And of course, AARP, Innovate 50 Plus, which is really one of the prominent organizations looking to promote very successful new technology solutions for this tens of millions of individuals, this huge market going forward. And of course, then our own resources, the Center for Technology and Aging. So with that, I'll thank you, and I think we'll hold questions until afterwards, and I'll turn the microphone over to Martin.
Thank you. Okay, well, I'm sensitive to time and sensitive to your attention and sensitive to your interests in technology and how you might be able to use it. But I'm going to talk a little bit about my background and the system that you've already heard something about. So I'm Martin Entwistle, and I'm from the Innovation Center, Drucker Center for Health Systems Innovation at the Palo Alto Medical Foundation. Funny thing is, a couple of people have already asked me this evening, what's innovation at Palo Alto Medical Foundation? Why are you doing that? Well, the truth is that our job is to come up, think of, understand the big drivers, the changes that are going to fundamentally change healthcare 3 years, 5 years out, and come up with solutions, end-to-end solutions that we can implement that are going to keep us ahead of the game. And 4 years ago, when we were first established, we were looking at a number of different possibilities. And this is the kind of issue that really was driven home to us. That currently systems like Palo Alto Medical Foundation, others, Kaiser, are focused on episodic sick care. And we already can see the drivers, the changes that mean we have to do something fundamentally different. We really have to think about keeping an individual as healthy as possible for the long term. That isn't a business that we currently run today. We do very well with people coming through our door when they're sick, and we treat them. We do a really good job of it. But what we have to work out is if that's no longer the business model, and that's all part of Obamacare and the shift to different funding that makes organizations like ours responsible for care over the lifetime of an individual and outcomes, we have to have a very different business model. So that was partly behind what we were thinking about. We then looked at a number of different problem areas, the working well, younger people, and of course seniors with the baby boomer issue. Now, one of the things that we do, principles that we follow in our Innovation Center is human-centered design. Hands up who knows about human-centered design. I hope most of you, because it's technology. All right, well, human-centered design requires you to understand what your customer wants. It's not rocket science, is it? But there's a discipline that we've used which is extremely useful, which is ethnography. Who knows about ethnography? A little bit. Who's heard of anthropology? All right, okay. Those are funny people that go out to look at people that live in jungles and tribes. Well, no, ethnography is about us. It's about how we live our lives. So ethnography is extremely useful in understanding what people are really doing. Now, we all know older people. Some of us are there or getting there. What's one of the things that older people are very good at? They're very good at accommodating. You look at the little tricks that people have in order to be able to carry on driving and go to the bathroom, and little things that they do. And these little things that they do, accommodations, are really important to understand. So our ethnographer went out and interviewed quite a few older people to find out what are the problems and what are your aspirations. And as you've heard, the summary is, as you can see on the slide, one of the biggest issues is about isolation. It's about the world closing in before you're ready for that to happen. You still have ambitions, you still have motivation, you still like to do things, but it's increasingly hard to do that. What impact does that have on you? Your motivation goes down, you become depressed, it compounds your isolation, and isolation itself leads into a whole bunch of medical issues, which is our fundamental business. So now we come back to, so why would Palo Alto Medical Foundation be interested in innovation and looking at this kind of problem? It's because very soon now, we're responsible for the impact of the problems that can be solved, not by more medicines, not by more surgery, but by doing some very different things that involve social engineering. So a couple of other things that our ethnographer picked up. Trapped in suburbia. We don't have environments that make it easy to be old. It assumes it's all people like us that can drive around, have got money to spend to get from here to there. All of you know El Camino Real, yes? I scare myself daily, me, trying to cross that street. Why? Even on a light. How many people can get across there before the light changes on you? Now think if you're 75, and as you've heard how important it is to move, and you live near that street and you've got to cross it just to go to your store. How many times are you going to try doing that before you give up and probably go home and become like that lady sitting there hoping that life was different? Not very long, frankly, is it? So there's a bunch of things there that need to be sorted out. And then we've got some other insight into, for example, this is a significant medical problem. What am I thinking about? You're probably thinking about infection and stuff like that. No, this trash can belongs to a 75-year-old lady who's living alone and she's not too steady on her feet. What's she trying to do every week? Take it out. Drag it out. And what's like to happen to her? She's going to fall. And then what's going to happen? She'll turn up at our ER with a fractured hip and we'll see it as a medical problem. It wasn't. It was a social problem because if somebody could have helped her drag her trash out, think what that could have done. So all of that factored into coming up with ideas as to how we can tackle the problems. So here's a bit of background information on the impact of isolation. As I said, it's pretty significant. Here's the other one. So because of isolation, a significant number of people, and you've already seen some of these facts, are totally reliant on their family in order for them to stay at home, living, thriving successfully. And how often is that the case that can be done? Increasingly difficult because sons and daughters are scattered across the country. You no longer have neighbors who are likely to help you. You no longer have friends because your world's closing in. What do? It's compounding your problem. And so we believe that in coming up with a solution, we needed to shift from this episodic sick care into thinking about care over the duration of someone's life, particularly their older life, and shift to a model that is much more focused on community and socio-behavioral aspects. And that's how we come up with linkages. Linkages focused on the social and behavioral needs and support for an individual, getting very much away from medical, although that's important, and coming up with a system that got a number of dimensions to help that process. Essentially, and this is really disruptive for a large healthcare system, it's a shift to support care in the community. Using community, remaining in the community, tapping into those extensive resources that exist in the community in a neighborly manner, if only we can find a way to harness them. And thereby hangs the challenge. So our solution has got a number of dimensions to it. So it does use technology, and great insight for you. A number of dimensions that you've already heard, great opportunities to be part of this process. First off, we're really not very good about understanding the needs of an individual. Who's at risk? Who's able to look after themselves? Who needs support? Who's got aspirations to do something? I used to dance. I used to like music. I really would like to get back to that. We just don't know those things. And so profiling, sounds a bit of a pejorative word, is about understanding individuals where they're at, their state and status. Next, if we understand that people that have got a need, then how do we match up people within the community, this neighborliness, community support, bring people together? How would we get the young guy who lives just down the street from that lady with the trash can to come in and take it out? He might be very willing. Probably at his school, he's being encouraged to go out and do community service. So time banking is about linking people up, using time as the economy. I offer to use my time to help you. You make requests of how you would like services. It could be mowing your grass, having a meal cooked, etc. A whole range of just normal day-to-day things. Nothing particular rocket science, and we don't have to transact one-to-one. So we can interact as a community, doing things with each other and paying, if you will, with the use of our time. Everyone's time is worth the same. Doesn't matter if I'm the President of the United States, if I'm involved in a time bank, an hour of my time is an hour of everybody's time. So we have that system up and running, and we've done it in Mountain View, and we're just expanding now further across the Bay Area. One of our other areas, and you've heard a little bit about this, is called Connect. This is about understanding individuals that are maybe at risk of going off the rails in one way or another. Essentially, it's about, are you doing your daily living activities successfully? The simplest way I can describe it is, we all know our mothers. We were asked before if we have them. I think everyone said yes. We all know if mum is okay. And we're only trying to reproduce the same thing. Mum is not okay today, and then someone with expertise could go in and find out what's going on. Because if we can find out that mum's not okay, then we can apply resources to prevent those falls, prevent other things that may come from Alzheimer's and dementia that we've heard about. And lastly, an area that we're just beginning to work on, which is List. This is Yelp-like. There is no shortage of databases of resources, of where you can get things, do things, etc. But it does seem like there's a problem in having them in a senior-friendly manner, in a system that seniors will trust, that is kept up to date. And so we're thinking about crowdsourcing a community resource system that will be kept up to date and will be senior-friendly and relevant. It's all about finding things that you need and making it easy to do that. So together, that's the linkages system. And it's fundamentally, therefore, about activating community, engaging with, linking across the ages, bringing multiple age groups into this process in support of seniors. But I thought I would close by just giving you some ideas on technical challenges. Put it the other way around for you. These are technical opportunities, areas that could be tackled. Firstly, there's an awful lot of work, as you've heard, and David spent time on this, is the ecosystem of monitoring. Huge opportunities for that, huge potential benefit, and yet right now it's pretty fragmented. We've got lots of people jockeying for position with fairly small focused solutions. How are we going to make some sense of that? Because be market focused. If you're on the other side of the equation, you're a senior, how many of these things are you going to buy? So if we've got 5, 6, 10 companies all positioning the same thing, be real. Do you think the senior is going to buy that number? So I think there's opportunities for bringing these together. There needs to be some ecosystem of these. David was also showing you, really, there's multiple modalities of sensing that are required in a home. So how do we bring those together to provide that in an easy to use, easy to adopt, affordable solution? So economy is another feature. Remember, we're talking about a market that's targeting seniors. And whilst there are some pretty wealthy seniors out there, in general, that isn't the environment we're in. Most seniors are price conscious. They're certainly very conscious of their resources and they want to keep them. Understandably, they don't know how long they're going to be around, and you've already heard what they're likely to face. My next step is moving into some kind of supported living, and it's $4,000 to $8,000 a month. You're going to eat through your assets pretty fast if you do that. So people are frugal, understandably. So how do we put these things out at a price point that actually matches the senior's appetite for buying things? And that isn't what we're used to in the younger population. So I suggest thinking about that. And lastly, one of the big areas, huge opportunity here, is about how do we build that connectedness? All the capabilities that we've learnt about from social engineering, social media, bring people together, drive those connections, and on the other side, understand how well of a job we're doing. Who's connecting with whom? Who can we put in touch with other people that are likely to drive better, stronger, bigger connections? Now, we've just run a developer challenge on this very issue. It's an interesting fact. So we had over 50 companies sign up to take part. We had over 30 companies download our data set. And then we were somewhat disappointed with the result in terms of the number of people that submitted challenge responses. What does that tell me? Big opportunity, and it's difficult. What does difficult amount to? You crack it, you've got a big opportunity because the barriers to entry are not insignificant. So for those of you that are interested and those of you that are working in this space, think about it. It's not easy to do because it's hard to actually get your arms around, but it's going to be really big. A number of people have already talked about the importance of community. Community in many dimensions is going to be key to the future. It's going to be very different than the way we currently think about health, welfare. We're going to have to rely on community. It's the only way this is going to be affordable. So those of you interested that want to get ahead of the game, think about how you can do engineering, management, organization of communities. Might be closed groups, might be wider communities, but big, big opportunity. I'm going to stop there. Hopefully you found that interesting. And Praveen, I think questions.
Sure. Any questions?
I think it's working. So I think it's directed to all of you because I think you touched on it but did not dwell on it. And this is the mental condition of the patient or a person who is in the living conditions, and what motivates or what attracts him or what he likes to do. And what is going on today in that regard, and where are the opportunities for that work to be enhanced?
Well, maybe I can make a comment. I think those of us who are getting older can already relate to, we still feel we have skills and would like to find avenues for them. Giving meaning in life, Deborah, I think you were talking about this in terms of, I want to feel that I'm valued and I want to feel there's value in my life. What's one of the really simple ways we can do that? By linking people up. I mean, many seniors have got wonderful experiences and wonderful skills. Actually linking them to the younger people who actually perhaps are the most appreciative of that wisdom, skill, and experience that's so different from their own. So there's a lot of opportunity, I believe, for making those connections as community and giving value on both sides.
Hi. Really interesting talks. Really enjoyed each one of them and loved the way technology is going to make a difference in seniors' life. Just a few comments and questions. One is our parents spend time and money on us, and we'll be spending time and money with our children. We'd like to spend time and money for our parents, but becomes difficult, I think, for many. And the communities will play a very big role. I help out with the ICC seniors, and I see that that community is so vibrant because all the seniors get together every day and they really enjoy it. Whereas at home, they're isolated, even though their children are around or wherever they are. So the other thing is technology adoption by these people. That is a challenge. And a lot of them do stay in our CFEs or home care or assisted care places. And the challenge there would be probably getting the caregivers and the administrators to adopt these technologies and show how adopting these technologies will make their life easier and make their patients' lives easier and more manageable, probably. And wanted to see if y'all could comment on that. The other thing is you mentioned that how many bands can somebody wear, right? I mean, each band is tracking just one item. And so the idea there would be like maybe an integrator of some kind, like with Apple or Google, who would create one band, but then there would be charms on that band or beads on a band, and that would like then it customized to each, like Pandora did for women, right? You customize those charms or those beads to what your needs are. It could be fitness for the more healthy people. It could be assistance in eating for those with Parkinson's, or it could be something else.
Don't say anything more. Go and patent it.
Go patent it. Okay. So anyway, there's some questions.
That is actually, there are new companies that have done, sorry about that. It's wonderful, you're exactly on target, that have started putting this together, actually in the form of jewelry, where you can connect different components. And again, it is the aggregators that are looking at it. And I'd like to pick up again on Martin's point, because the real game changers here, the winners, are going to be the platforms, people who can pull these different technologies together, because we have too many individual, and this is where a lot of folks run into trouble as entrepreneurs or trying to get into this space, taking on incremental components of the system when we're really looking at systems where a person changes over time, has multiple issues, and you need to have multiple items. Because again, as I believe as Praveen was saying, people are not going to be purchasing multiple devices. It's just not practical. Those are going to be the successful companies going forward.
I just make a comment. Sorry, go ahead. About technology, because we've already heard some figures this evening about adoption, and I think it's greater, faster than we give credit for. I was talking with a senior population at a senior center just last week. Said, how many people have got smartphones? Now, it was in the valley, but it was probably 90%. But I said, so how many of you would have put your hands up if I'd asked you this question 2 years ago? And it was probably about 25%. So, I mean, the rate of uptake. Why? Because I think they're interacting with their grandkids. It's a great, I mean, the comment spontaneously, how would we do without it? Was, that's the point they've got to. Now, I think the challenge is in the older group. So the people that are 75, 79 plus who, are not there. I mean, it's going to be self-limiting because as people age and are used to the technology, they'll bring it through. But I think our hardest challenge is how do we find appropriate technology for the older people who are the ones that we really need to intervene with? Don't know the answer to that.
My name is Ramji Patel, and I'm a social activist engaged in ICC TAI for 17 years. I'm 78 years age. I've seen what you have, I listen very carefully what you all have said, scholars, but there is a practical solution for that. And the last speaker who emphasized of solution to get family together, community together, but unfortunately, the old American system which has turned into a new American system. So is with the Indians. They've started not believing in a family. And that is the biggest problem I see. My experience goes from Africa, England, here. So only solution is the community involvement all the time. Like I give you one example. My wife has had a problem, breathing problem, and luckily because I'm slightly educated, I got how can I measure her oxygen. And I took an oxygen meter with me, and believe it, I went for my granddaughter marriage, and luckily I knew what to do. And when we are coming back, 2 hours to land, her oxygen went up to 33. And it would have taken only 2 minutes before she get brain dead. So gadgets are not important only. Teaching them. We have got so many seniors who have got multiple gadgets. But to use it is a problem. Memory is a problem. So simplicity and coordination. And it should be like a Dad's army after Second World War, which helped England, should be implemented also here and use the Dad's army, right, to support the seniors.
Very good. Very good idea.
Sure. One more. Please give a big round of applause for all our speakers.